Good afternoon and good morning to folks out there on the West Coast. Welcome to today's event for NACHC's COVID-19 Learning Series, Looking Over the Horizon. This is a part 3 of our series and the last one for today, sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NACHC, and I'm pleased to bring you this event along with my division colleagues, Cheryl Smith, the Director of the Quality Center, as well as Luke Ertl, the Program Manager of the Quality Center. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event by either physically calling in or using computer audio. All attendee lines have been automatically muted and will be muted for the duration of this event. The duration of this live event is approximately 60 minutes, including introductions, presentations, and Q&A. Again, the duration of this live event is approximately 60 minutes, including introductions, presentations, and Q&A. Today, we will have the chat box open for the duration of this event. The chat box is located in the lower right-hand side of your computer screen and will be available for any sort of comments, questions, or concerns throughout today's webinar. We'll be also posting any sort of resources our presenters may mention throughout today's events in this chat box. So super important, if you wouldn't mind just taking a moment to locate that. Again, please paste in any comments, questions, or concerns into the chat box by simply typing your question, selecting the to everyone or to all panelists, and just making sure you hit the enter on your keyboard. And that's the only way that we'll be able to get that information onto ourselves. Periodically, we'll be actually taking live questions as well. So if you feel as if you would like to pose that question verbally to us, feel free to use the raise my hand function simply by either taking your cursor and hovering over your name. A little hand icon will pop up. Just simply click on that. That lets us know that you'd like your line to be unmuted. Again, we'll be taking most of those raise my hand questions at the end of today's webinar because we have plenty of content that we want to deliver out to you today. So again, two ways that you can pose your questions throughout the chat box or using the raise my hand function. Friendly reminders that today's event is being recorded and will be posted online within 2 to 3 business days after this webinar has been completed. All attendee lines have been muted and will be muted for the duration of this event. The chat box will be available for the duration of this event by simply typing your comments, questions, or concerns at any time throughout today's presentation. And then last but not least, you'll be presented with a brief 4-question survey after the completion of this event by a pop-up window that will also be in the chat box as well. Your comments and your questions, and obviously all of your survey information is so important to us. It lets us know how we did, how valuable this event was to you, and if future informs us of events and technical assistance that we can give to you in the future. At this point, I'm going to turn things over to Cheryl, who will be taking things over from here. Cheryl, the floor is yours.
Great, thank you. And again, welcome all to our 3rd and final session in a 3-part series on building health center capacity to respond to COVID-19. This series is made possible through funding from the Centers for Disease Control and Prevention as part of the NACHC's COVID-19 related support and efforts. Similar to our webinars in October and November, today's session will explore 3 topic areas. Switch for a moment so we can see those lined up. And I think we are having a little technical difficulty in advancing the slide here. If I could get some assistance in advancing the slide, and I'll just continue on with my statement. So next slide, please. All of the focus today will be the 3 focus will be business continuity planning, data and informatics, and next slide, please, and promising practices. And
Cheryl, give me 1 moment. The slides are frozen, so just give me 1 moment and I'll get it taken care of. Thank you.
That's okay. While you adjust the slides, I'll continue with a few comments about setting the stage. So our content begins today with a focus on business continuity and the importance of business continuity planning to survival and sustainability during COVID-19 and other emergencies. And for this portion of our program, we're going to start with Jervine Williams, who's Director of Finance, Training, and Technical Assistance with NACHC. Welcome, Jervine. I'll turn it over to you, and you could speak both for your team and introduce your co-presenter, and then we'll also allow, while you're kicking off your comments, for Liz to get started. So thank you, Jervine.
Okay, thank you so much, Cheryl, and welcome everyone to the webinar today. I'm really excited with the CDC project and business continuity planning. We're partnering with PCDC, and Isaac's going to talk after I finish. We're partnering with PCDC to make this valuable tool for you guys out in the field. Next slide. So, next slide, please. So we have 3 different parts of this. First, we have an action guide, which we're still under review. And this action guide is kind of like a summary of the business continuity plan. Then we're going to have actual tools and templates that will be housed on our Elevate platform that you can download and edit and use freely. And then lastly, we're going to kick off a business continuity planning learning session. And we're going to leverage our Elevate platform in order to deliver this content. So we'll have the dates in early January 2021, so you guys can sign up and get the more deep down details of all the business continuity planning and the tools and templates. And with that, I'll turn it over. Next slide, I'll turn it over to Isaac to go through the action guides. Isaac?
Thanks, Jervine, and good morning or good afternoon, everyone, depending on where you are. So as Jervine mentioned, our first deliverable and thing that we really want to put out to all the health centers is an action guide. It's going to cover the 8 steps on the screen. I'm not going to read through them, but really, what are the things that a health center can and should do well in advance of any pandemic or public health emergency to really minimize the disruption to their ongoing business as a result of that public health emergency or disaster. It obviously starts with identifying what your essential business functions are, what are the core systems and processes you need to keep up and running. It then moves on to really looking at the impact of any disruption to those services, and then starts to look at, developing a business continuity plan. So what steps and processes will you put in place in response to any public health emergency to keep those essential business functions operating? And then it closes out with really, how can you do an exercise and really debrief on what it would look like if you were experiencing an emergency or a disruption. You can go to the next slide. So steps 1 through 4, and again, this will be carried through the action guide as well as the training sessions that will be scheduled in the new year. Again, really starting with identifying essential business functions and then looking at your cybersecurity risks. I know that's a hot topic right now, both as a result of the pandemic and just increased cybersecurity threats across the country. If you go to the next slide. And then the concluding steps 5 through 8, which I went through on the action guide document, but it really, continues with developing that business continuity plan, making sure you have everything in place or a plan for everything if your business is interrupted or disrupted, making sure you set aside time and sufficient resources to test and exercise that business continuity plan and cybersecurity action plan, and then really doing sort of after action reporting, identifying gaps in your preparedness, in your business continuity plan, and making sure that, when the real thing happens, that you have the right team together, you have the right processes put together, and you have everything identified in advance. So again, just in closing, this will come out in an action guide, which is really sort of quick tips on how to implement this, as well as into actionable tools that you can use to support business continuity planning within your organization, and then a final sort of training curriculum to provide support on how to best use those tools. Next slide.
Great. Thank you, Isaac, and thank you, Jervine. So again, part of NACHC's work in supporting health centers in the COVID response is to be able to support you through action guides, through training and resources around business continuity planning. So we provided a brief kind of introduction and laid the foundation during the course of these 3 webinars. For those of you who are interested in diving deeper, applying the action guide and getting technical support, stay tuned for more information in January of how to join this learning forum and dive deeper into the business continuity piece. Another critical component, as you can see on the screen, in our support efforts around COVID-19 are with regard to developing data infrastructure and data aggregation and analysis. And so we're going to dive deeper over the next portion of this webinar in that area. And with that, I'm going to turn the floor over to Dr. Julia Skapik, who's Medical Director of Informatics with NAC. Julia?
Okay, hopefully my network will tolerate the video and audio here and not bum out on us. But thanks everyone for joining us today. We're talking about sort of the third component of our COVID-19 multi-state project with the CDC. And I'm very pleased that we have Jennifer Dumont, who's one of our partners from the Alameda Health Consortium, to join us and talk about how COVID-19 data can be used to help support good care decisions and operations of health centers. We can go to the next slide. So this is just sort of a quick reminder of what the multi-state data effort is. The 6 states in dark blue are the locations of our partners, which are CCNs and PCAs, and then the light blue states are other states where they have FQHC members. The goal of this project was to build infrastructure to help us gather data to support public health, quality improvement, and hopefully to connect health center partners to innovation opportunities. And our goal for this project is to understand sort of what the burden or impact of COVID-19 is on health disparities, health outcomes, and health utilization. Next slide. So we are starting now to gather our first set of preliminary data. We're sort of taking a test run at data collection, which is something we recommend for everyone. Don't assume your first batch of data is going to necessarily be good enough to get you all the way you want to go. So we started by doing some sort of feasibility work, asking our partners, do you have the particular data we're asking for? If not, are there sort of surrogate measures we could use? Are there additional things that we forgot that might be useful? We added flu vaccination actually after the first version of our data dictionary. But what you can see if you look at this data set, and this is not comprehensive actually of all of our partners, this is a partial data set, is that there's a predominance of PCR testing happening in the FQHC world, that about 10% of the tests end up being positive. That's for all of the different COVID tests. What we see overall is that about 8% of the patients that were reported in this set of 900,000 unique patients, about 8% of them reported a positive COVID diagnosis, and that was either using sort of a clinical diagnosis or using a test-based diagnosis. We are tracking, as I mentioned, flu vaccination because we're expecting to get COVID vaccine data with sort of the first set of patient-level data. We get monthly reports probably starting in January. So the flu is sort of a test run that may be a useful frame for all of you if you're not doing COVID testing yet to sort of start seeing how easy it is to extract high-quality data. Next slide. So these are our current measures here on the left. As I mentioned, we're sort of trying to understand who's being tested, who's diagnosed, who's being seen in person and virtually, and how that layers out with different demographic variables. What we're looking to also measure, and we're sort of cleaning up these data, and our partners are working to fill in data capture gaps, is who is being vaccinated for COVID-19, what the impact of social determinants of health are on patients with and without COVID, how the clinics are responding to that. If we can get data that's good enough to tell us about COVID-19 outcomes, so ideally, if we could get some hospitalization data or even death data to add in, looking at some mental health outcomes and impacts on insurance and employment, which we're tracking for our patients. Next slide. All of you are probably familiar with the PDSA cycle. The thing I want to really emphasize here is that the measurement is a critical component of PDSA, because in order to understand what the impact any changes you're making have on the practice and the outcomes, you need to have actually an accurate measure of what the before and the after numbers look like. So using that then in a continuous feedback loop actually enables a PDSA which is much more effective than one which is very sort of intermittent or waterfall. What isn't measured, as I said, is very hard to improve. You can't tell if you're doing any better or not. So it's key to sort of at the very outset make sure that you have the information you need. One thing we see a lot in informatics is there exists a place to record a piece of information, but it's rarely recorded, so that information is not usable. Next slide. So I'll pass it over to Jennifer. Thanks so much for joining us today.
Thank you, Julia. Hi, everyone. My name is Jennifer Dumont, and I'm the Senior Data Analyst at Community Health Center Network. Next slide. So just a little bit of background first. We are a managed services organization based in Alameda County, California, on the east side of the San Francisco Bay. We serve 8 different health centers, 7 of which are FQHCs, and 1 which falls under the Indian Health Services, and all serving a large portion of Medicaid patients. Next slide, please. Oh, sorry, go back. We have a sister organization, the Alameda Health Consortium, which is the policy and advocacy arm, which is directly advocate for the needs of our health centers at both the local and national level. We serve over 270,000 patients and over 95 clinical sites. And we're contracted with 2 local health plans, the Alameda Alliance for Health and Anthem Blue Cross, to provide the Medicaid services to our patients in the area, and that includes primary care, most of the specialty care, and the service component of hospital-based care. So as a result, we are specially situated to have access to a lot of different kinds of data. We have all the information about the claims that we process. All of our clinics also migrated to Epic over the past 2 years within one instance hosted by OCHIN, so we have direct access to this unified EHR database. In addition, we receive periodic supplementary data from our health plans for pharmacy, behavioral health, and additional inpatient and ER data. And all this has been tremendously valuable as we have addressed the COVID-19 crisis. Next slide, please. So today I will highlight 3 distinct uses for our data as it relates to COVID: telehealth encounters, COVID-19 clinical diagnosis and testing data, and our clinical quality measures. Next slide. Next slide. So first we'll go into the telehealth encounters. So early in the pandemic, after shelter in place, this dashboard served as an internal reference on how well our clinics were doing at the transition to telehealth. So you can see kind of, I realize the text is small, but this covers from before shelter in place, which in California started about mid-March, all the way through, it goes up to October on this chart, but it continues. And so you can see originally there are virtually no telehealth encounters, and then very quickly we ramped up from like very few up to about 1/3 of all total encounters being telehealth encounters. And this is actually an internal database based on our claims information. So there are a bunch of filters available to the people who have access to this dashboard that are not shown, one of which is looking at the actual service provider. So if we filter this down to the clinics alone, it's actually about 2/3 of encounters are telehealth encounters, and they've already matched and even exceeded their capacity of encounters prior to the pandemic. So understanding the clinic efforts for telehealth has informed our understanding of tech support needs and drives our ongoing work. We have work groups and projects specifically for enhancing our ability to provide quality remote care. And we continue to monitor this data for emerging trends. Next slide, please. So next, I'll show the diagnosis and testing related data. So first, this view shows data related to our total patients, and they're categorized as infected, exposed, or suspected. Data for this comes from the EHR, and it includes encounter diagnosis, the problem list diagnosis, registry, and lab results. We have demographic data for each of these patients to understand who the populations are that are most affected. And using the filter at the top, we have a date of service filter, so we can look to see how that changes over time. And this is specifically used by our Chief Policy and External Affairs Officer to advocate for our clinics, specifically looking at the race and ethnicity table here. If you go to the next slide, we also have it broken down by sex and age group, We see cumulative patients over time, and then there's also this access to the patient details table, so our clinics can see for a specific patient what date of service they were seen at, what the ICD-10 code, diagnosis, category, and description were. Next slide, please. This second view is the tests that were ordered. So similarly, we have total tests, positive, negative, and positive rate. Right there at the top, easy to see. We can see which tests are still pending. I'll note here that this is actually not comprehensive for all of the tests that our clinics are performing. Several have large community testing operations, and because that includes people who are not their regular patients, those records are actually not input into our EHR, and this is EHR specific. So this, while it shows quite a good number of tests, is not even the full scope of what our clinics are doing. And then quickly the next slide. So this is a snapshot of the patient and test level data that our clinics then have access to for each test. So they can look up a specific patient by name or by medical record number and see what the result of any tests are that have been performed. Next slide. And next. So lastly, I want to highlight our clinical quality measure tracking. As I mentioned at the beginning, we're contracted with 2 health plans in the area, and as a result, we focus primarily on HEDIS measures for clinical quality. We've been tracking multiple measures for quite a while, and this is a three-year view of some of these measures. While there is some variation over time, a lot of the results were fairly stable, at least until this year. So you can see kind of that last third drops off for several of our measures. And if we go to the next slide, here I've zoomed in on 2020 and just a few of our measures. So the red lines are roughly the start of shelter in place in the Bay Area. And I want to highlight the controlled blood pressure measure first on the left. So due to the specifics of the measure, this one actually did not drop as dramatically at the beginning of the pandemic, but by routinely monitoring this data, we were able to quickly identify the trend that started to emerge in August and September and use that information to advocate for more resources for our health centers. And our health plans have come through. This data has helped move forward remote patient monitoring systems with financial support from both of our health plans. Moving into the new year, we expect to see a significant increase in the number of patients using remote monitoring of blood pressure across our network. Similarly, the data related to A1C testing and diabetes measures in general, which are the other 4 on this slide, that has been steadily dropping since March, but it has informed new efforts to get home test kits for A1C testing. And while the compliance decreases for these measures were certainly predictable, our existing dashboards and ongoing monitoring have been instrumental in understanding the extent of the issue, and they will help us further in monitoring the impact of the next wave of interventions. Thank you.
Hi, Cheryl, you're muted.
Thank you. Just turning it back over to you, Ray. Thank you.
All right. Good afternoon, everyone. My name is Ray Madua. I'm the physician informaticist with the informatics team with NAC. And just to nicely transition what Jennifer presented just now is what do we do with all of this data that we're getting? And I wanted to introduce what's called electronic case reporting for those who don't know what this is. So ECR is kind of the automatic generation and transmission of case reports, such as their patient records, which has specific diagnostic codes and stuff, from the EHRs in patient charts in the outpatient, in community health centers, hospitals, to public health agencies such as the CDC, so that the data that you're producing in your clinics becomes actionable. And onto the next slide, you will see what's the value of doing ECR. So again, it's automatic. Healthcare providers don't need to manually input all of this data into a separate system where they need to abstract or type it or copy and paste it from their system to another system just to do public health reporting. It supports real-time data, and I'll show it to you later in another slide where how does this affect a real-time application of evidence-based care into your workspaces and your workplaces. And again, we're trying to close the loop with ECR now because healthcare providers receive the information back from the public health agencies once they receive your data. So that's what ECR, electronic case reporting, is. And on to the next slide, we will see the current implementers of ECR, or electronic case reporting in Texas, Utah, New York, California, and of course our multi-state partners like OCHIM. You can see some similarities here. Some bigger electronic health record companies such as Epic are submitting ECR case reports. But again, the list is just getting bigger and bigger, and we at NAC are trying to link community health center data to contribute to these public health agencies so that the data that we are getting in our catchment areas will actually be actionable also and represent our population that we're serving. On the next slide, we will see how it happened. So the currently existing electronic case reporting infrastructure, we start from left to right. So from the left-hand side, you'll see the providers who are using the EHRs, and then it gets transmitted to a cloud platform, or in the middle, it either goes to an health information exchange or your multi-state agency or HCCN/PCA partners who are gathering all of this data to report it to a system or a platform. So the AIMS platform is what the CDC is using. And then they package it and aggregate it and submit it again directly to which specific division in their public health agency is doing. And what's currently happening during COVID times is there's something called ECR Now, Electronic Case Reporting Now. So ECR Now makes it even easier for you or partners or clinical health centers, for example, who might not necessarily have an EHR system like Epic that supports electronic case reporting, to implement electronic case reporting right now, especially during times of COVID. So if you want to get in touch with them, we at NAC and the informatics team can help you connect your organizations with the CDC and the ECR folks. That's why ECR is important, because it tries to close the loop. CDC will get your data and make it actionable for your specific areas and not just urban areas or big hospital systems. On the next slide, I will show you again another thing. This is called the Nationalsyndromic Surveillance Program. So ECR and NSSP are both from the CDC, and the difference here is the NSSP, or syndromic surveillance, traditionally captures emergency department data because they want to capture patients going to the emergency department who are experiencing, for example, strange coughs or flu-like symptoms. The NSSP, which is a bunch of really great epidemiologists, are capturing all of this emergency department data and modeling it, so they have a predictive model to see if, hey, looks like these flu-like symptoms, there's something might be going on in this area. Maybe we better investigate. This might be an emerging threat. So you can see that instead of being a reactive health system, contributing to your data to public health agencies who are creating these predictive models makes us into a proactive health system where we are already ready when there is an emerging threat. So you can see this nice infographic shows how people seek treatment, right, in the medical facility, and the data goes to NSSP, goes to CDC and provides analytics and pushes it back again to the community so that the community gets the latest evidence-based care based on the same data that they are contributing. So what we're trying to do is not just use emergency department data. We understand that some people don't want to go to the emergency department. Maybe it's expensive. Maybe they don't have insurance. So that's what the community health centers are there for, to accommodate those who don't necessarily want to go to the ED because it's expensive. So we're contributing the similar or maybe surrogate data that can help these epidemiologists predict these emerging threats. On the next slide, we can see, we'll start in the bottom, number one. Within this infrastructure, how well are we reporting these kind of rules on what kind of data or what kind of, for example, infectious diseases are we monitoring? Cough? Are we monitoring a sore throat? Stuff like that. And then this goes back to number two on the top left. Within the healthcare providers, are there trigger codes aligned with the EHR workflow? For example, if there's somebody who is an elderly patient coming in for cough, who might be a suspected COVID patient, are there trigger codes in the EHR that will allow your system to submit this and package this to be submitted to these public health agencies? Number 3, is your data complete or accurate? That's also very variable. Number 4, is the case detection rate accurate? So the positive predictive value or sensitivity, which is the true positivity rate, for example, for COVID. You want to see what the true positive rates that we're seeing. And number 5, again, bringing back the loop or closing the loop, wherein can person-based data or patient-based data be automatically integrated and linked with things that are happening in real time, such as, for example, there's this patient, we're monitoring it, their target population, they might be at risk for COVID or really like high morbidity, high mortality signs and symptoms. How can we loop that back and see, hey, maybe this patient needs to get these immunizations, or there are new labs, or there's these new treatment protocols that can lead to better clinical outcomes. And on the next slide, again, we can see there's just a clearer picture of how this feeds into each other, and healthcare providers see on the field and public health agencies. And we really want to support this, because if you look at what EHR data is being used for, public health use is at its lowest. So now that COVID is here, it further highlights how all of this important data we're producing in our community health centers or everywhere need to be reported back to public health agencies so that we can have actionable data in the field or on the field. So on the next slide, again, there are different places where we can get their actionable points. Or, for example, on the left, you have your healthcare provider. What are information that we can do that are actionable, that gets fed back to the field from the public health agency, from these surveillance information systems. Again, your data gives them and informs them for what actions are needed, and then what they get from that loops it back to you guys back in the field. And that's what we're trying to do in COVID. And moving forward, we're trying to support that. And you, our community health center partners, hope you understand the value in using the data and harnessing your data to impact a bigger change or a macro change in the way we do our patient care in the community. So thank you very much.
Wonderful. Thank you, Raymond, as well as our whole team presenting on data informatics and HIT. I think as we transition today, we started again talking about supporting health centers in business operations and specifically around business continuity. Then we had a terrific presentation around data aggregation, analysis, and really connecting health centers and partners to information, to the system that Raymond just described. And so, again, really the power of data analysis, using that data to drive decisions, policy, et cetera. And we heard that from Ms. Dumond as well. So thank you for that. And we're going to transition in our third part of our session now to hear from a health center. And oftentimes in these series, we begin with, again, business operations, HIT and informatics, and then we like to bring to life an example or examples from the field and what we call kind of best or promising or innovative practices. And so today we're thrilled to be hearing from a health center. It's South Carolina, regarding a unique approach that they are using in providing virtual care during the pandemic and lessons that they're learning and can be applied by other health centers. And so with that, we're going to, I'll introduce in a moment Dr. Duncan, but before I do, I want to say just a few words about the national initiative that she's a part of, and again, we'll describe their particular experience. This is a national program called Leading Change, Transforming at-Home Care. It's a project that's funded in part by the Centers for Disease Control and Prevention. There's 10 health centers funded under that cohort and another 10 funded under HRSA. And so a total of 20 health centers representing 17 states. And really the idea behind this project is to provide tools, and I'll share in a moment what those tools are, but to put in the hands of patients tools that they can use for self-care and to use those together with providers and care teams as part of the virtual care experience that many health centers are doing more of in this time of COVID. So if you take a look at this map, you can see a bit about our cohort that's scattered around the country and, again, representing a range of different states, some large, some rural, urban, again, a mix of different health centers in this initiative. What you can see on this screen are the components or the supplies that are provided to the participant health centers to in turn give to patients or provide to patients as a part of virtual care. And so we call these patient care kits. And again, you can see on the screen that those include home colorectal cancer screening tests, home blood sugar, blood pressure monitor, scale, thermometer, again, all part of a patient care kit designed to be used in the home with the patient, communicating virtually with visual capabilities with health center care teams. So with that, I think I'll turn it over now to Dr. Drjaniqua Duncan, who is Associate Medical Director with CARE South Carolina. Dr. Duncan, just to share a little bit about her work, she actually began as a medical student and National Health Service Corps Scholar and moved into her current role about 3 years ago, where she heads up many of the clinical and team-based initiatives, including work with value-based contracts and managed care organizations, and also participates in their center's engagement with the Institute for Healthcare Improvements Leadership Alliance. She is the project lead for CARE South Carolina in NAC's Leading Change Project. So with that, I'm going to turn it over to Dr. Duncan.
Thank you, Cheryl. So thank you for allowing me to share our work. So just to kind of take you through what we've done on this project roadmap, in the laying the groundwork segment, we decided to use our nurses that had been doing our annual wellness visits for our Medicare patients to be the frontline staff to execute this project. So we already had that team established, and I worked with them there. As far as our planning, we already had some telehealth and telecommunication policies and procedures in place, particularly due to COVID and that shift. So I was able to take those policies and procedures and adapt it to this work with the at-home care. So as far as training, we at CARE South have done our communications via videos. So during this time of COVID, our CEO would do a weekly video to kind of summarize what's going on, what our COVID task force was working on, and then also each week someone in the leadership team would do an update. So I use that same methodology to produce a video for all of our staff at CARE South to describe the project, show the tools that we were sharing with our patients, and explain to them this whole process, and that went over very well. We also use technology, we use Microsoft Teams to train the RNs as far as how to do the visits and also how to do the work with the patients and as well as their EMR template documentation. So like I said, our team was established, and I feel like with new programs and there's always so much in the air and anxiety about doing something new, the fact that the RNs and I had already had a working relationship was very good. As far as launching, we used our Azara tool to risk stratify our patients. I created a registry which built in the criteria for the patients, and I reached out to those patients. So during those baseline visits, once the patients were recruited, both of the nurses actually participated in the baseline visit, and they wanted to do that, one, because they felt more comfortable doing it at the same time and learning, but we also found it to be valuable because now the patient had two faces that they connected with. Another practice that we thought was super helpful was that we asked our patients to bring their technology with them to the baseline visit so that they could practice using it. One of the survey questions at the baseline visit is, to rate their experience with telemedicine or telehealth, and most of our patients had not experienced it, so having them bring their tool to that baseline visit was super helpful just to get them connected and feel more comfortable. You can go to the next slide, please. So we did have some challenges. As of Monday this week, which seems like quite a long time ago, we went live with the new EMR. So the baseline visits were done in our old EMR system, which was GE Centricity. And then starting today, on Monday, we started with eClinicalWorks. And so luckily I was on the team that helped with the implementation and build. So I was able to build in a template for our RNs, and as soon as they got their training, I met with them to train them on how to document in the EMR. Another challenge that we've had globally at ClearSouth as far as IT is really what Isaac was talking about. Our host, NetGain, was a victim of a ransomware attack, which means that ClearSouth was too. So we've had interruptions in our email. I still can't get into my email today, into our EMR, into our Microsoft. So that's been challenging for the team to continue to do the work without the technology, but they've been doing great despite those challenges. Next slide, please. So we've had wins already, which is super exciting. So there was wonderful response from the staff to that introductory video. I actually had some send me emails talking about how proud they were to work at CareSouth and for the fact that we were putting the energy into executing this program and providing these tools for our patients. So I thought that was super great, particularly in this time of COVID when everyone's kind of stressed out and just kind of feeling down. So I think that was really great to hear that from the staff. We've also had a patient success story that I want to share with you. So there was a patient that we recruited. She, met the criteria, reached out to her, and she came in for her baseline visit. She was very upset and crying during a lot of her interview, and her concern was that her phone didn't have any minutes on it. And the nurses spoke to her more, and she had some issues with her boyfriend. Her boyfriend kicked her out the home. So she had no medications, which included her diabetes medicine and her depression medicine, among others. And she just really was frazzled, didn't know what to do. And so the nurses were able to work with her to get her into one of our other offices because now she's living with her family in a different county that we serve. They worked with the community health worker there at the office to get the patient emergency medications on that day of her baseline visit. The nurse practitioner at that office actually happened to be off that day, but her nurse was working, and the nurse called her cell phone, and they were able to get her scheduled for the next available appointment. And she actually had her follow-up appointment, her December appointment this week, and she's doing much better. She's been taking her medications. She's been using her tools at home. So we're super excited about that, too. We also had some community response. We used the press release that was given as a template to all of the participants, and I worked with our marketing team to send that out. And I received a call from one of the representatives at the First Steps wanting to partner with CareSouth in some cancer screening outreach. So the press release was very successful as well. So that's just a quick summary of what we've been doing so far, and we feel privileged to be able to participate in the at-home care program.
Great. Thank you, Dr. Duncan. Wonderful. And again, wonderful job. I think I didn't say at the beginning kind of the timeline for this. So it was a fairly rapid startup in September and October in terms of laying the groundwork that Dr. Duncan spoke about, with November and December really being launched in those baseline visits that she referenced. And then those virtual visits, applying the patient care tools, will continue in the 20 health centers, each working with 20 patients over the course of January through June of 2021. The good news for all of you in the field is that the workflows, tools, and resources that are coming out of the experience of these 20 health centers will be shared nationally. So one, we already have some toolkits available, and we'll be making those available nationally and publicly in January. And then again, other success stories, lessons learned, and tools coming out of health centers like CareSouth Carolina will be available during the course of the springtime. So I think with that, I'm going to loop in my colleague, Luke Girdle with the Quality Center, and we'll transition into a Q&A session. And Luke, why don't we turn it over to you and see what kind of questions we have coming in for any of our speakers today.
Thank you, Cheryl. So we've got a couple questions that came in first. This will be directed at Jennifer. So Jennifer, what at-home test kits were you using for A1C, and what Bluetooth-enabled blood pressure cuffs were used for remote monitoring?
I do not have details on all of that. The A1C test kits are actually being provided by Anthem Blue Cross, so we don't have the brand information specifically on our end. But as far as the blood pressure kits, I know that each of our health centers is sourcing those independently. I know that one of them is using Omron as the brand. I don't know specifically which model, but that's from one of the grants that was provided via OCHIN. They're using the Omron blood pressure monitors.
Thank you very much. And we had another question come in, and I think Ray had started addressing it in the chat box, but wanted to make sure that everybody was talking, or everybody was able to see it. So the question was, how might we estimate the number of persons getting SARS-CoV-2 tests per health center who aren't regular patients who have EMR records?
Oh, thanks for that, Luke. Oh, yeah, sorry. So there are different ways of doing this. You can work with Zara or your population health management system or whatever software or a third-party company you're using. If you really want to find your first-timers, and I think Laird, Florida mentioned that at PanCare, they were able to run population reports and look at the number of visits, for example, during the public health emergency right now and find their first-timers. But you really need to work with your data people, and you wanted to find out where your testing centers or sites are aggregating all of this data. Are they disparate from your community, your health center EHR system? Are they talking to each other? If not, you might have to find a middle ground and figure out a way, work with your data people. If you don't work with your data people, just talk to your testing center. And you can kind of do some patient ID matching. If you're not sharing patient IDs or not sharing your master patient index, it's possible you might do some fuzzy matching where, let's say, the first name and the last name and the age can match and see whether or not they're a regular patient. And so we really want to see if we can link their testing data with your local EHR data, and that involves working with your vendor or working with, again, your SARS-CoV-2 testing vendor. So that's a really good question, and yeah, hope that answers it. Thanks.
Thank you, Ray. And we also got some additional questions, or one additional question that can go to either Dr. Duncan or Cheryl Modica, as well as Jennifer. But how is the information from the A1C home kits, accessed by the health centers?
Sure, I can answer. So during the follow-up visits, the patients perform those tests. So they will do their blood pressure and their weight and temperature, and when it's time, the A1C test while they're doing the video visit with the nurse, and then they'll record that in the EMR, as well as any of the logs, temperatures or blood pressures or weights that they've done over the time period that previous month.
And just to build on Dr. Duncan's comment, that's excellent. And all of the health centers, it's been laid out in that same way, meaning that in these, again, 20 health centers each receive 20 care kits. And the expectation is that while the first visit, as Dr. Duncan described, is often face-to-face for the purposes of, or I should say it's a blend. Some are doing it virtually, some are doing it face-to-face. But face-to-face is certainly allowed for that baseline visit. But then the subsequent visits are expected to be a virtual visit with that visual or video capability. And as she pointed out, the expectation is that the care team is visualizing the test to be done. I think to answer one of the earlier questions, the home A1C test that's being used in the care kits is the PTS diagnostics test. It is a box of 4 tests that the patient is receiving. And then the blood pressure monitors that are used in the Leading Change project are the Omron 10 series. It is a device that is on the validated list, and it is a 2-user device. And one of the things that we're informally hearing feedback in is that in particular has been very valuable. Not only is it a validated device, so can be used, again, assuming that your you're either electronically getting the results, or a provider or care team member can visualize the device to be able to see the results, then it can count for a UDS measure. But the other important feature of that Omron 10 series is that because it is a 2-user system, many patients are in homes where there are family or other individuals who may have an interest in checking their blood pressure. And so one of the training aspects is to be able to instruct patients that, user 1 setting is for them only, and so that there isn't any corruption of data or any, infiltration of that result, and that if they're going to share it or allow family members, for instance, to take their own blood pressure, that should always be done on the user 2 setting. Again, just to separate those results and not corrupt any of that data. So, thank you.
And building off of that and adding a little bit more information about the blood pressure devices, we had one comment come in from a NAC colleague, Meg Metter, saying that a good site for blood pressure devices is validatebp.org. I'm putting that into the chat right now. Another question that just came in a moment ago is the PTS A1C test result also accepted for billing and UDS measures?
That is probably one of our most frequently asked questions by the health center teams participating, and unfortunately at this point it is not. Part of the purpose of this pilot project is to gather data, gather information on the experience in using these tools in the home setting. I think for blood pressure devices, particularly validated devices, there's been a lot of experience, been much more experience in self-measured blood pressure or use of home devices and that sort of thing. There's been less experience, or at least less, I think, formal documented experience around things like A1C tests in the home, or again, remembering that we are doing the colorectal cancer screening test with the expectation that result or that sample then needs to get back to the health center. So those are kinds of things we are going to learn, are learning, and are going to continue to learn in terms of what are the best workflows, or what are the experience with different workflows. What are some of the strategies that health centers have found effective? Is this tool, for instance, PTS diagnostics tool, is that an effective tool in the home center? We are finding some early experiences that shows it is a bit finicky. If you look at the data for the test itself, it has, in terms of its accuracy, the data supports it. But again, if it turns out that it is my word, finicky or somewhat challenging tool to get consistently accurate results, it may not be the best tool for home use or for our patient population. So those are the kinds of things that we are hoping and expecting to learn through the pilot project. And I guess the last thing I'll say, because I saw a question, was who is running the project. So again, NAC, the National Association of Community Health Centers, operates the overall project. There are 2 streams or 2 cohorts. 10 health centers are funded on the HRSA side of the house, and 10 health centers are funded on the CDC side of the house. But from our perspective, it's a cohort of 20 that are together walking through that project that's overseen or facilitated by NAC.
Thank you, Cheryl. At this moment, I only have one additional question that's come in, so I want to again encourage everyone to go ahead and send in any questions that you have via the chat box. But we've received several questions about how you can access either the slides, the recording, something along those lines. And I'm going to put in the chat box here in a moment the link that you will be able to access all this information. It will be the slides, the recording, and the transcript as well here in a moment. So take a look at the chat box for that link.
Okay, so Luke, while you see if any additional questions come in, I'll move on to our 2 last slides, just so folks have a little bit. Again, this is our last in a 3-part series, and in part looking over the horizon. And it's exciting to say that even in the course of this short 3-part series, we now have a COVID-19 vaccine in the field. And so just a reminder to folks, if you weren't already aware of this, that health centers, in order for you to deliver a vaccine, regardless of whether it's the current Pfizer vaccine that's in the field, which may or may not be the appropriate vaccine for many health centers, there's a number of different vaccines in the pipeline. In order to administer any of those vaccines, you must complete a vaccination provider enrollment process and form. And so again, some more details here and a link to help to support you in that, and certainly to connect with your local jurisdiction, your health department, in terms of more information. And then finally, please do join us for what we call Ask Me Anything. These are Friday sessions. This Friday session, again, each of these are about a half hour or are a half hour in length. And this is really to focus on a term that you may hear more of in recent days around microplanning. And essentially that means, how do we take the national strategy for vaccine distribution and create a local or health center-based, certainly not only your health center-based, but even with in your local community or with partners, that microplanning or more local level execution of COVID-19 vaccination. So really, any questions you have around vaccination, COVID-19 related to flu vaccination, again, we encourage you to be putting the word out about flu vaccines and really couple COVID-19 efforts and thinking and marketing around your flu vaccination program. But do join us on Fridays from 12 to 12:30 Eastern Time and bring any questions. We have Claire Hannon, who's Executive Director, as you can see, with the Association of Immunization Managers, and she joins us each Friday to answer your questions and to provide more information. I think with that, if folks have additional questions, we've had several presenters on the line today, and I know they'd be happy to follow up. I'm happy to direct any questions or follow up to them, or again, in many cases, you may have their contact information from the slides. Luke, I'll do a final check back to you and see if we have any more questions. And at the point you're ready, then we can close out today's session.
Thank you, Cheryl. We had one additional question come in related to behavioral health, but are there any strategies used to address behavioral health impact on patients and providers?
And Luke, was that related to COVID vaccination? I'm sorry.
Apologies. It came in right about the same time that you started, so no, not related to the COVID vaccines. Okay.
Ray, were you going to take that?
Yes, I think I can answer that question. Strategies are really difficult because it really depends on the capability or your capacity of your health organization or your community health center. Telemental health is really big right now, and there are a couple of organizations that are trying to make sure that we don't have a lot of available psychiatrists who you can talk to, especially with the increase in mental health challenges that our communities are facing. And so one thing that your organization can do to address mental health challenges is see if you have a telemental health program. If not, you can look at your workflows and try to mimic what has succeeded in other community health centers, so you can try to explore what's on the internet. I have nothing on the top of my head, but there are some programs by the CDC and the American Psychiatric Association they have some toolkits that you can use to address these challenges in your community. So that's a great question, and it's oftentimes overlooked. But we at community health centers, I think we should also have that in the back of our minds, that it's really not just COVID. Families are affected by what's happening and how our communities are impacted by the morbidity and the mortality of this pandemic. So that's a really nice question to ask. Thanks, Phil.
Thank you, Ray. With that, as Cheryl said, we'll go ahead and wrap up. I just want to call to everyone's attention that your feedback is important on these webinars, so I will be putting a link in the chat box for you to access a short survey just to give us your feedback on the content and the presentations today. Thank you all.